I'm really pleased to introduce Dr. Elizabeth Vig. She's an associate professor in the University of Washington School of Medicine, Department of Medicine, Division of Gerontology and Geriatric Medicine. She's board certified in both geriatrics and palliative care. Her clinical work in geriatrics and palliative care is based at the Seattle VA Hospital, where she's also chair of the hospital's ethics committee. She's participated in research investigating how people with serious illness and their families make difficult decisions about the kinds of care they receive towards the end of life. And today she's going to be talking with us about ethical dilemmas in the care of older people with cognitive impairment. Welcome, Dr. Vig.
Thank you. Can you hear me?
Yes, we can.
Oh, good. Okay, because I am not right near my phone, but try to do it so everyone can hear and see stuff. Okay, here we go. Welcome, everybody. So let me start with some disclosures. Some of these slides that I'll use are adapted from a presentation that Tia Powell did and are used with permission. Some of the other slides have been adapted from the VA's National Center for Ethics in Healthcare, also used with permission. I don't have any financial disclosures, and what I'm going to say doesn't necessarily represent the VA opinion. Just keep that in mind. So objectives for this session, I'm hoping by the end of this, you all will be able to explain one difference between clinical ethics applied during ordinary times with public health ethics applied during pandemics, and then describe a framework for approaching ethical dilemmas, the cases approach, which I'll go over, apply a framework to cases involving individuals with cognitive impairment, and then reflect on how our own beliefs and values may be influencing how we respond in certain cases. So the way we're going to get through all of that is I'm going to start just talking briefly about ethical principles during ordinary times and pandemics, talk a little about the effect of a pandemic on the care of people with dementia, and then talk about ethical dilemmas in the care of people with dementia during ordinary times, go over a framework for approaching ethical dilemmas, and then apply the framework to some cases. I've got several cases. We may not get through all of them, but they'll have the slides so you can look at them on your own. So starting with the basics, I'm talking about ethical dilemmas. What is an ethical dilemma? And this is one way to think about it. So it's a situation in which there is uncertainty or a conflict in values between stakeholders about the right thing to do. Okay. And thinking about clinical ethics and the principles that we use, especially here in the US. So autonomy is a big one, right? That is rooted in our respect for persons, an obligation to promote patient self-determination, and it's honoring the patient's capacity to make basically their own decisions. And I've got my big, huge autonomy here to remind me that in the US, autonomy is really huge, right? Maybe even more so than in some other countries where what the person wants may not be the be-all and end-all. I'm at the VA, and at the VA, autonomy is even bigger than it is outside the VA. Autonomy isn't the only principle. There's also beneficence, where we're trying to do good things for our patients, non-maleficence, where we're not trying to harm people, and then justice, where we are going to treat people equally and we are going to try to have fair and equitable distributions of benefits and burdens. These other principles during normal times are less important than autonomy, but you'll see when we talk about pandemics, things shift a little bit. And so, lo and behold, this is a pandemic, and it's sort of a weird, surreal time. So I thought having this surreal picture to represent it would be good. So how are things different? Well, there are kind of three levels of standards of care, and people have started, at least here in Washington, I realize people calling into this presentation may not be in Washington, and where you are, things may not be as crazy as it's been here yet, and I hope it doesn't get that way for you. But a lot of these terms were new to me, but I thought I'd go over them just so that we're all on the same page. So there are these three standards of care, and this is the way we function and take care of our patients. So they're conventional standards, meaning sort of the good old days of a month ago when, you know, we did things the way we always had. Contingency standards are when there is something like a pandemic or a natural disaster, and there is a risk that we may not have adequate supplies of what we need to take good care of people the way we're used to. So right here in Washington now, we are under contingency standards of care. We're not changing anything the way we do things, but we're starting to do lots and lots of planning for a time when we might run out of things and have to ration things. And if we got to that point, then it would move to this crisis standard where things really are different. And during a crisis standard, we then move to public health principles instead of our usual clinical ethical principles. So the ones that become important if we move to crisis standards are, one, respect. So we're still going to honor human dignity even for the people who we cannot provide the kind of care that they might want. We're going to ensure fairness in decisions, right? We're going to have specific algorithms or criteria that we're going to apply so that we are treating people equally and we are being fair in the decisions we're making. Transparency is also important, especially for leadership. They need to be very transparent about why they are making decisions the way they are, so that us, the little guys, understand this and we continue to trust them. And then during crisis standards, justice becomes really important. So achieving the greatest good for the greatest number, meaning we've now shifted away from autonomy to justice and doing everything we can to maximize the most good outcome. So it's really sort of a different approach. And for people who are used to the good old days, it can feel really pretty awful. A couple other values to be aware of during a pandemic. So there's the duty to care, meaning all of us in healthcare have special knowledge and skills and expertise. And at a time like this, we are obligated to use those to help other people. And we should be willing to take a proportional risk in the care of patients and not to abandon them. But on the other side, we have organizational reciprocity, meaning the organization that we work for has a responsibility to support us and to protect us and to try to keep us safe when we are stepping up during a situation like this. Okay. And I put this here just to sort of show the tension between clinical ethics, the regular way that we're used to doing things, with public health ethics. So on the clinical ethics side, we're going to focus on honoring patient autonomy, whereby on the clinical or the public health ethics side, we're going to focus on achieving the greatest good for the greatest number, which is a utilitarian approach. A little more about this tension. So again, on the clinical ethics side, we're going to be focused on the individual. We're going to provide patient-centered care. The patient preferences and values are really going to help us make decisions for what that patient wants and what they get. And we have advocacy and fidelity to the patient. But again, if we switch to crisis standards and this public health ethics becomes our main way of doing things, community becomes sort of the important thing, not the individual anymore. We look for the common good. We consider all people morally equal, and we try to distribute what scarce resources we have fairly, and then follow protocols to ensure that we're doing this fairly and we're treating people equally. Okay, so hopefully that makes sense. And so then thinking, because these are sessions about taking care of folks with cognitive impairment, what is the impact of the pandemic on the care of those with cognitive impairment? And this may be obvious to people, but I hadn't really thought about it before, and so I think I'll just put it out there. So one, there is restricted liberty. So in the US, we're sort of used to being able to go wherever we want, whenever we want, and all of a sudden there are all these mandates saying that we can't do that. So there are, you know, for somebody with cognitive impairment, there's going to be a lot of reduced activities, maybe reduced outings. If someone is in a nursing home or assisted living facility, there will be visitor limitations. A lot of places aren't allowing any visitors. So then there's decreased socialization. And people sometimes, at some places, even have to stay in their rooms or their apartments. So that even adds increased isolation to all of this. The caregivers taking care of these folks may be, more stressed than usual. They may be exhausted. They themselves have the risk of getting sick. And so if they're really stressed and exhausted, they may have reduced patience for the person with cognitive impairment. There may be reduced interactions with them, which leads to reduced quality of care, maybe quality of life for the individual with cognitive impairment. And then all of this, often people with cognitive impairment, especially, more advanced cognitive impairment, may pick up that those taking care of them are more stressed than usual, and that may lead them to sort of getting more stressed and anxious as well. There also may be variable understanding of the situation and why somebody can't go outside for walks anymore, why their family can't visit, etc. I put this in here just to make a point. I just learned about this last Friday, that the UW Brain Health and Wellness Center is offering these various community events that you don't have to be part of this clinic or program to participate in. So if you Google this and go to this site, people can join these virtual coffee chats. You have to register beforehand. You have to sign up and register, but anybody can participate. And then they have these caregiver forums, which I think can be helpful to caregivers, especially if they're feeling isolated. And then these virtual community wellness talks. So that might be something to offer the folks you're taking care of as a resource. So back to the ethical dilemmas, thinking about some ethical dilemmas that may arise during a pandemic. So the caregivers may be really stressed out about, how do they get food? Do they take their loved one with them to the supermarket and put them at risk, especially if the person won't wear a mask? Or do they leave them at home and hope nothing helps? Or hope that the person doesn't get into trouble. Another dilemma may be what to do about medical care during this time. Do you take the person somewhere if they get sick, etc.? And there's some, fairly easy solutions. You can get food delivered, you can get curbside pickup. There may be sort of ways to think about this. Here at the VA, and I think everywhere else, all of a sudden telehealth is being used everywhere. And so that might be an alternative to taking a person somewhere where they might get exposed to something, keeping them safe, but also getting the medical care that they need. Another dilemma is whether someone with moderate or even severe cognitive impairment is going to get scarce life-saving treatments during crisis standards of a pandemic. So if we didn't have enough ventilators and someone with severe cognitive impairment came in, would they get a ventilator, or would somebody else get it? And I think, you know, I'm thankful that here at the VA they have, we have a scarce resource allocation team that has formed, and triage teams who, if we get to that point, would be applying algorithms to make some of these decisions. That takes the burden off decision making off any one individual, because having that burden of having to make that kind of decision would be really hard. So if you have a group of people who are applying an algorithm, that can make it, one, fairer and also easier psychologically for the people deciding who gets what. And I think during this time, it's also going to be important for people to be thinking outside the box and trying to come up with creative solutions to some of the new problems that we're encountering. So in working with patients who have cognitive impairment and their caregivers, just thinking about ways to help them plan for whatever is coming next. If it gets bad, if it, you know, who knows? None of us know what's coming next, right? So maybe it would help them to strategize on ways to meet their basic needs. This is going to be a time when advanced care planning is really going to be important, and I'm going to get back to that in a couple of slides. Does the individual with cognitive impairment, did they ever complete an advance directive? Meaning, have they designated someone to be their durable power of attorney for healthcare? Should they get sick, and should decisions need to be made for them? Did they complete a living will, which might give us a sense of what they might want? If they haven't completed this, can the person with cognitive impairment or even dementia complete one? I would argue that people with even moderate dementia might be able to complete a durable power of attorney. They might be able to understand if they got sick, who they would trust to make decisions for them. The other thing to think about is encouraging the caregivers. You know, have they completed these documents for themselves as well? Because they're also at risk of getting sick. At the bottom of this slide, I just mentioned the dementia advance directives. I think you guys are going to get a separate section, a separate one of these talks on that. So I'm not going to go into that, but just be aware that there are some advance directives online specific to dementia that people may want to be aware of. So in a pandemic, even if there's not a pandemic, I think it's really important for people who are at risk of losing decisional capacity to have designated someone to make decisions for them. And if they haven't, for us to be aware of who their legal decision maker is. And so I put a couple of different lists here. Every state and the VA have these laws that designate what they call a legal hierarchy of surrogates. And so if someone loses decisional capacity, they can't make their own decisions, and we need to go to someone else to ask them what they would want, the way to find the person who can legally tell us what the person wants, we go to the top of the list, and then we work our way down until there is one or more people in that category. And then that group are the legal decision makers. I'm not going to get into the weeds too much. Different places, some states say that suppose if you get down to adult children and there are 5 kids, Some states say that they're consensus states, meaning all the kids have to agree. Other states say a majority, meaning only 3 of the 5 kids have to agree. State of Washington changed their rules in 2019, so it used to just go down to adult siblings, but now it has additional people on the list, which I think is great. And as I realize that some of you who called in are not either in the VA or in Washington, so I put this here. The American Bar Association's Elder Law section actually has a site where you can actually look at the legal hierarchy laws for every state. So if you Google American Bar Association healthcare decision making, you'll then get to a site where if you go down on the site, you will see something that says default surrogate consent statutes, and that'll get you to a document that shows every state's law. There's some other interesting stuff on that site, so check it out if you want. But that's a way that we can find out who somebody's legal decision maker is. So I alluded to advanced care planning before, and this is just a little more. I think it's much easier to think about this stuff and to decide what you would or wouldn't want before there's a crisis or an emergency. So I think encouraging people to think about this while they're doing okay. So one way to think about it is, overall, what kind of care would that person want? Often there are kind of 3 different levels of care that someone might choose from. So there would be full treatment, meaning that person would be okay going to the ICU, being on a ventilator, getting dialysis, sort of the whole shebang, right? Then there's selective treatment, meaning the person would be okay going to the hospital and maybe getting IV antibiotics on the regular floor, but they might not want to go to the ICU if they got sicker. And then there's comfort-focused care, meaning you prefer not to go to the hospital. If you get sick, you would want us to do everything we can to keep you comfortable and keep you at home. So that's one way to think about it. Additional things to consider ahead of time, would the person want antibiotics or feeding tubes? Would they be okay with hospitalization or ICU transfer, like I mentioned? And then thinking a little bit about code status. I think it's, if I'm having these conversations, I often start, way back what's important to the person first before getting to code status. Often I'll talk about that last and translate what I've heard about what's important to them with what code status that fits with that might be. Here in Washington, we have the POLST Form, which stands for Physician Orders for Life-Sustaining Treatment. And it is a form that can kind of outline somebody's preferences and is useful outside of the hospital should somebody call the paramedics. They'll come and they'll honor it. Some states have these and have different names, some don't. But this is something that may be helpful for somebody to fill out ahead of time. And then having these conversations can be really hard and kind of scary. And recently, different groups have actually come out with kind of COVID-specific tips for having these conversations. So I put these 3 resources here for you. Vitaltalk.org has new COVID-specific talking points with specific things you can say, which I think are quite helpful. You can go Google VA Goals of Care Conversations. There's some materials there that may be helpful. And then the Prepare for Your Care group has also come out with some stuff in the last couple of weeks. So you can check out these different resources that may be helpful. And I think, encouraging the caregivers to think about what plan B is going to be if they get sick. who's going to take care of their loved one, what's going to happen, et cetera. And having those plans figured out ahead of time may really cause a lot less distress should the caregiver get sick. So I think that's all I'm going to say about pandemic stuff. I'm sure you guys are sort of pandemicked out. So let's skip and do something different. Okay? Okay, here we go. Back to ordinary times. Back to the good old days. Remember the good old days when you went to movies and restaurants, and you went for a walk in the park? Oh my gosh, it was great. Anyway, so here are some ethical dilemmas in dementia care during ordinary times. And this is not an exhaustive list by any means. So one, whether to share a dementia diagnosis with either family members or with the individual with dementia themselves. Whether to promote continued driving or voting or independent living by somebody who has dementia. Whether to honor preferences of the then self, i.e., when I was okay, I said I would never want X and Y and Z. Or do we look at the now self, the person with dementia, and what they seem to care about and what they seem to enjoy? Would we want to give or withhold antibiotics in advanced dementia, or start tube feedings in dementia, or even withhold food and drink according with a directive in someone with dementia? So lots of ethical dilemmas that could pop up. And ethical dilemmas can make people really uncomfortable and really stressed. And there's sort of that, what do you do feeling. And so I like to present this approach, the VA cases approach. It's an approach that ethics consultants at the VA nationally use to kind of think through the ethical dilemmas that are brought to us. But I think having a framework in your head can be really helpful when you encounter something like this, to reduce your stress so that you, instead of just, oh, this isn't right, what do we do, being able to kind of think through it. And so cases is a mnemonic. There are 5 steps, which I will go through. You clarify the request, you assemble the information, you synthesize the information, you explain what you've come up with, and then you support the process. I think I sent a copy of this cases pocket card for a handout, but you can also just Google cases pocket card, which is a little trifold that goes through all the different steps. So, step 1, clarify. So, is the thing that's giving us distress, is it really an ethical dilemma or not? And as I said before, if there's an ethical dilemma, there is going to be uncertainty or a conflict in values between different stakeholders about the right thing to do in this situation. And the conflict might be between the patient and their family, it might be between 2 different parts of the family, it might be between the family and the clinicians, it might be between the clinicians and policies or laws. And I also think it's really important always to be aware of what your own values are, because there are certain issues that get us all riled up for whatever reason. And I think if we went around, different people get riled up by different stuff, because we're all human. And so if you're aware of the things that get you riled up, I think that's important. So if I'm the ethics consultant and have our pager, and the pager goes off and I call someone, there are certain issues that I am not capable of being unbiased about. And if one of those issues comes through and I have the pager, I'm going to find one of our other consultants to manage that case, because it wouldn't be fair to the requester. So step 1 is to figure out if this is ethics or not. Because sometimes people are really distressed and they somehow think that ethics has a magic wand to poof, make everything better. but maybe it's just a really dysfunctional family that's driving everyone nuts. Or maybe they're calling us about a question that's not actually an ethics question, it's a legal question, or it's a privacy or an information security question. And so if that's the issue, I need to make sure that I get that distressed person to somebody who can really help them. Okay? So once we've figured out that this really is ethics, then what I want to do is come up with a question. And sometimes it's really hard to try to put what someone has just talked to you about on the phone for 20 minutes into a question. But I think it can be really helpful when one is distressed and you're running into one of these situations to try to figure out who are the stakeholders whose values are really in conflict. And that could be helpful. And so we'll come up with this question, and I'll give you an example of one a little later. So given the conflict between stakeholder X's value of A and stakeholder Y's value of B, is it ethically justifiable to do or not do Z? So an example, given that this patient's advance directive says that he would not want life-sustaining treatment in the event of a stroke, and his durable power of attorney for health care feels that his stroke wasn't so bad that he wouldn't recover and he actually would want continued care. Is it ethically justifiable to, continue aggressive life-sustaining treatments or to not? So that kind of gives you an example of it. Some of these questions, because you're trying to outline everything, they get super long, super run-on sentences. Oof, I think my 7th grade English teacher would have had a stroke if she'd seen some of these. Anyway, moving on. So that was step 1. Is this really ethics? And what is the conflict that's creating this ethical dilemma? Once we have the ethics question, then we can figure out what information do we need to actually answer that question. So we're going to assemble information. And what kind of information might we need? Well, we usually need medical information about the patient's situation, maybe about their prognosis, about the different options out there. So we would gather that. We definitely want to know about the patient's preferences and interests, right? What do we know about what they want? What have they said to us? Have they completed documents, etc.? Who are the other parties who are involved and what are their preferences? That might be family members, that might be the clinicians, that might be the patient's sort of ethnic or racial or spiritual community. We also want to know about ethics knowledge, meaning can we find anything out there? Has anyone else encountered this same issue, and have they written anything about it that might sort of help inform us at all? Are there policies that are important, that are relevant? Are there laws? So we might need to find all of that stuff. We probably want to meet the patient and maybe meet their family as well to hear their perspective. We want to talk to the involved clinicians. We want to talk to others. So we're gathering information in this step. Some people have used the 4-box method, and I would argue that it's valid. It's a slightly different approach, but the 4 boxes are kind of similar to the assemble stage or step, okay? So we have our question, and then we gathered all our information, and now we have to make sense of our information. That leads us to this 3rd step of the synthesize step, where we're trying to sort of figure things out. We're going to do an ethical analysis. And one way to do that is to kind of look at the different options that are on the table and what are the consequences to the patient and the other stakeholders if we go route A, what's going to happen, versus route B, what's going to happen. We also can look at the case through different ethical lenses, which I think is the next, hold on, let me just see. Yeah, it's the next slide. So we'll go through that because that can be helpful as well. And then we're going to come up with recommendations back to the person who called us and was distressed. And we're going to resist the urge to fix everything. Because if we try to do that, we are going to burn out in no time. So keep that in mind. A lot of these situations we cannot fix. They may not even have a happy ending. So I mentioned one way to do this synthesis is to look at cases through different ethical lenses. And so just having a sense of what they might be, so I mentioned the principles at the start of this, we might balance, see how the different principles are balanced if we go different routes. We may want to see if there are previous cases like this that have been written up, and the way they were written up and how people argued things might be helpful for us. Again, looking at policies and laws, and sometimes professional codes of ethics come into play in terms of what we as clinicians can and can't do in certain situations. Sometimes it's helpful to weigh the harms versus benefits of different options. Sometimes it can be helpful to look at the duties of the different stakeholders in this situation. And sometimes looking at rights can be helpful. So once we have done our ethical analysis, then at least as ethics consultants, we usually write things up and we go back and explain how we thought this through to the people who were involved or to the distressed person who called us. And I'm not expecting all of you to become ethics consultants, and yet I think if you spend the time to think through an ethical dilemma using this approach, it can be really helpful to share your thoughts with other people who also may be distressed. And then the last step, the support step, again, isn't as relevant if you're not an ethics consultant, but I think it's important to keep in mind that sometimes the same ethical dilemma keeps coming up in an organization over and over and over and over again, right? And if that's the case, then it may be time to think about systems issues that are leading to that and whether a systems level intervention might help stop that. You know, periodically at the VA, new policies come out that then, you know, make certain issues go away. Such as we used to get lots of consults about people who had oxygen dependent COPD who continued to smoke, and a lot of distress around that. And then a new national policy came out about oxygen management and smoking and took care of the issue. So hopefully that's an example that makes sense. You can learn more about this. The VA's integrated ethics site, it's more user-friendly than it used to be. So feel free, if you just integrate or Google integrated ethics and then click on the ethics consultation link, there are a fair number of resources that may be helpful, examples of various cases that may help you think through things, etc. So with that, I've talked a long time already. Let's at least get through one of these cases so you can see how this gets applied. So we're going to apply our cases approach. We're going to start out by thinking about whether there really is an ethical dilemma here. And to figure that out, we're going to think about whether there are conflicting stakeholders and conflicting values, what those are. We'll come up with an ethics question. We'll think about what facts we need to answer our question, what our analysis is going to be, and what recommendations we would have in this case. Okay? So So here's a case. Oh, and I have pictures from the internet on these cases just to make the slides more interesting. They're not the real people. In fact, these cases are kind of made up, so there isn't a real person, although it may sound like people that you've taken care of. So this first case is Mr. A. He's a 73-year-old man who was brought to his PCP by his family after he disappeared for several days. He lives alone with his family helping him. Family finds him irascible and forgetful. He got lost while driving and ended up in a different state. He denies evidence of a fire in his kitchen about a month ago. He tells his physician, "If I have Alzheimer's disease, don't you tell my kids. They're always in my business." Okay. So step one, we're going to apply our cases approach. Is there an ethical dilemma? Is there a conflict in values between stakeholders about the right thing to do? And so I think there is. So what are some of the conflicting values? Well, there's Mr. A, who doesn't want his family informed of a dementia diagnosis. Then there's his PCP, who thinks his family may need to help with medical decision making. The PCP also isn't sure whether HIPAA prevents him from informing the family, even if ethically he thinks it's okay. So we actually have two questions in this case, one ethical question and one legal question. And so the ethics question, and again, these are long, I warned you, given that Mr. A may have dementia and does not want his family informed of his diagnosis, but his clinician believes that the family may need to help with decision making, is it ethically appropriate to inform his family? And then the legal question is, does HIPAA prevent clinicians from sharing information with family members when cognitive impairment is present? And so if I was the ethics consultant and I came up with these two questions, I wouldn't answer the legal question, but I might reach out to our lawyers and get their input and then report that back. Or I might just put the person who had asked this question directly in contact with the lawyer. So we've got our question, now thinking about what information we're going to need to answer it and who we might need to talk to. So here's some ideas about information we might want. Well, medical information, first we have to figure out if Mr. A actually has dementia, right? We haven't even made that diagnosis yet. Then we might want to think about whether he's got decisional capacity to make a decision to not inform his family. I think it's also helpful to know why he doesn't want his family informed. And then, you know, what does HIPAA say about informing others when cognitive impairment is present? So does he have dementia? So you examine him and you find that he's got cognitive impairments in multiple domains and it is affecting his function. So yeah, he has probable moderate dementia. Why does he not want his family informed? What does he say? They'll just try to take my car keys. They were already after me to stop driving, and it's just none of their business. And he denies any abuse by his family. If that was the issue, then yeah, you'd be a little wary of informing them, and you'd probably be calling Adult Protective Services, etc. The family seems to be involved. They come with him to clinic visits. They've been helping him with transportation, housework, food, etc. So we don't have any concerns about the family at all. It's just him and his concern about them taking his car keys. So in looking at his capacity, whether he really understands what all this means, he is aware that he's got memory problems, but he's not really able to engage in a discussion about dementia or why having family involved may be important. His sole reason for withholding information is just this driving thing. So, you probably really can't make this decision. He does, though, express some values, which I think are valid and will be helpful in making decisions going forward for him. So he finds that maximizing independence is really important. He would really like to avoid being in a nursing home if possible. That's weird. He wants to spend time at home, and he says he wants to spend time with his family. He says his adult children are good kids. So he really lacks the capacity to withhold the dementia diagnosis with them. He can't weigh the risks and benefits, and his choice to not tell them doesn't really fit with his goal of staying home and being independent. So just to comment that capacity is going to be a decision-specific issue. He may be able to make other decisions, such as figuring out who he wants to make decisions for him. And as I mentioned before, his goals may still be valid. So even though he has dementia, the fact that he says that he cares about it being independent is still something that we aren't going to ignore. So he doesn't want his family told, but doesn't have decision-making abilities to understand that. So I would argue that it's ethically appropriate to tell them and to involve them in decision-making for him. What about HIPAA? Here is some language from the HIPAA law where the individual is incapacitated. Covered entities generally may make such uses and disclosures if the exercise of their professional judgment, the use or disclosure is determined to be in the best interest of the individual. So that's a lot of fancy lawyer speak, but my interpretation of it is that it is okay to share this information with the family. So ethically and legally, you're good to go. So case resolution, Mr. A is informed that the clinician needs to involve his family in decision-making. The clinician assures Mr. A that efforts will continue to involve him in decision-making. The family is involved of his diagnosis and reminded that he really values his independence. The family is informed about the course of dementia, the ways to promote his independence, and provided some resources from the Alzheimer's Association. So take-home points from this case, HIPAA reminds us to protect privacy, but not prevent care when it's relevant. Perform and document capacity evaluations, and then clinicians may disclose against the patient's request when the patient lacks capacity, when persuasion, not coercion, but persuasion fails, and when the benefits to the patient really do outweigh the burden. Okay? So let me just look at my watch. Let's do one more case, because I want to make sure that there's time for questions as well. So here's the next case, and again, picture from the internet to make the slides more interesting. So this is Mrs. C. She's an 88-year-old woman who has heart failure, hypertension, atrial fibrillation, chronic kidney disease. She also lives alone. She was admitted last month for delirium, secondary to a urinary tract infection. She's admitted this month after a fall. She's in the hospital. PT and OT recommend that she go to subacute rehab. But she's a feisty old lady and she insists on going home. The team insists that this isn't safe. So applying our cases approach, step one, is there an ethical dilemma? Is there a conflict in value between stakeholders about the right thing to do? And I would say yes. So Mrs. C wants to go home. PT and OT thinks she needs subacute rehab. And her medical team doesn't think she's safe to go home and want to require her to go to rehab. And there's often a backstory with these cases. In this one, the backstory is the team is concerned about liability if they allow her to go home. So writing the ethics question for this dilemma, given that Mrs. C insists on going home, but her medical team believes this would be an unsafe discharge and wants to require her to go to rehab, what are the ethically appropriate options for her discharge? Okay, so that's the question that we're going to try to answer. So thinking about what information we might want to answer that question. Oh, before I get to that, I got a little point here. So this is a case where on Mrs. C's side, on the left, we have the principles of autonomy and self-determination, right? We're not in crisis standards of a pandemic, we're just regular times, and so we're going to honor her decisions about, what happens to her. On the other side, though, in conflict, we have the medical team who want good outcomes for her and don't want to harm her. And some people on the team in these cases actually feel that sending her home would actually be causing harm. But I make this point about social work because in these cases, social work gets stuck in the middle because they are patient advocates, but they're also part of the medical team. And what I found is in some of these cases, the medical team feels that the social worker isn't a good team player because they're advocating for the patient who wants something else. So just be aware of that. Social work has their own dilemma in this specific case. Okay, so we had our ethics question, then I went on my little tangent, and now what information are we going to need to answer that question, right? What information do we need? Who do we want to talk to? And so we might want to think about what's the institution's policy on informed consent. That can often be helpful in these cases. We probably want to know why Mrs. C wants to go home. And we want to know if she has decisional capacity to make that decision to go home. So we'll need to think, who else might we want to talk to? And again, thinking about our own personal thoughts about this case. Is this something that maybe we can't be unbiased about, that gets us all riled up? And so I have an excerpt here from our VA informed consent policy. It basically says that you need to provide information to patients, talk about the recommended treatment or procedure, talking about the benefits and risks of that procedure, and then the alternative treatments and procedures. And then I like this part. We use this part of our policy when we get these consults. The practitioner is prohibited from attempting to persuade a patient to consent to a particular treatment or procedure by denying or threatening to deny the patient access to another procedure or treatment. Meaning, if Mrs. C really wants to go home, you probably don't, and if she has decisional capacity, it's not okay to say, well, we're going to send you AMA, we're not going to give you any of your medicines, and we're not going to set up any of your follow-up appointments. Not okay. Then there's this part of it too. The patient may revoke a prior consent even if that decision may increase the risk of serious illness or death. So patients who have decisional capacity, who understand the risks and benefits and alternatives to something, can make a decision that might even increase their risk of death. That makes us uncomfortable, but they have that right. And then thinking about Mrs. C and what is her reason for wanting to go home. So there are different possibilities. One, maybe she has previous experience with nursing homes. So an example maybe Mr. C was in a nursing home prior to his death and had some kind of awful experience, and every time she even gets close to a nursing home, when she goes to visit some of her friends, she kind of gets PTSD. That would be a reason why maybe sending her to a nursing home wouldn't be the best idea. Maybe she wants to get home because of other duties that she's got. I'm always amazed when there's somebody who's just barely making it and they have to go home because there's actually someone in worse shape that they're taking care of, right? Or maybe it's a cat or dog or somebody that they need to take care of. If we understand what that is, maybe we can sort of start brainstorming about getting that being the care that they need while she gets the rehab she needs to get stronger. Maybe it's a psychotic belief, right? Maybe she believes that the CIA runs nursing homes or something, you know. If that's the issue, then she probably does not have decisional capacity, right? Maybe she's still delirious. And maybe it's just unrealistic expectations. You know, she's lived on her own for, you know, the last 70 years, and who are we to tell her what she needs? So I alluded to this before. Does she have decisional capacity to refuse rehab? So if she does, then I would argue that coercing her to go to rehab by refusing to refuse her meds or scheduled follow-up, etc., is unethical, and it also goes against that policy that I just read you, right? I'm also in Washington State, and in Washington State, there is a state law that facilities can't hold people against their will. And so this is the state law that says no residential treatment facility which provides nursing or other care may detain a person within such facility against their will. So, hard to send her someplace if she doesn't want to go. And then, you know, if it turns out that she doesn't have decisional capacity to refuse, then we're back to the situation of we need to figure out who her legal surrogate is. And what does that person say? Excuse me. Ooh. Allergies, not COVID. So again, I've already showed you this. This is, at least here in Washington, if she's in our VA hospital, we would look at the VA hierarchy. If she's in a different hospital in Washington, we'd look at the Washington hierarchy. And again, American Bar Association, you can find the hierarchy for your state if you're someplace else. So we had our question, we gathered our information, and now thinking about the ethical analysis, weighing the different options. So this is simplistic, but I think it gets the point across. So if we're looking at the options and the consequences of those options, if we say sending her home is okay, that's going to honor her preferences. That may cause clinician distress, but this isn't really about us. This is about her and what she wants. And yes, there is a risk of injury or hospital readmission if we send her home. But if she's got decisional capacity and understands that, she may be willing to take that risk in order to get to go home. And then on the other side, looking at the option of sending her to a nursing home against her will. Well, that is going to disregard her preferences. It may reduce clinician distress. There may be a lower risk of injury or readmission. I think it's kind of funny. At least here in our hospital, people often think that, you know, if you send a patient to a nursing home, they're not going to fall. People fall in nursing homes all the damn time. I mean, they might be found sooner than if they live by themselves, but you're not going to get rid of that risk of falling. The last point here is that if we were to send her to a nursing home against her will, if she had capacity, it's basically illegal. So that's, you don't want to do that. Okay. So making recommendations. So sometimes clinicians kind of get stuck in the fact that there are only two options, right? We're going to either send her home AMA against medical advice, or we're going to send her to a nursing home. But I think, again, thinking outside of the box, are there alternatives that might not be quite as good as sending her to a nursing home, but might be better than just sending her home AMA, right? So could we get visiting nurses? Could we get some home PT and OT to help her? It might be helpful to do a home safety evaluation. They could look at medical management to make sure that she can take her medications properly at home. Maybe we want to think about getting her meals on wheels, so we're comfortable that she's got the food that she needs. Often we'll prescribe those life alert, you know, those little buttons that you wear around your neck that you push if you fall, and then it calls someone who could come check on you. And then, especially now, there's all kinds of home telehealth that may help. Here in Washington, we used to have this geriatric regional assessment team. I think they have temporarily folded. I'm hoping that they'll be back, because they were a group who could go out and check on vulnerable older people in their homes. Another thing that sometimes comes up in these cases is, you know, well, if she goes home, we're going to call Adult Protective Services. Okay. Does she meet their criteria for a vulnerable adult? So at least in Washington, these are the criteria. So someone has to be 60 years or older who can't take care of themselves, or somebody 18 years and older who has one of the following. So somebody who has a legal guardian, or who has a developmental disability, or lives in a licensed facility, or gets in-home services with a licensed hospice or home care agency, or someone who has an aide who is paid to provide care. So case resolution. So ethics in this case weighed in that if Mrs. C has decisional capacity, she can make a decision that the medical team doesn't agree with. The medical team decided that she does have decisional capacity to decide about her discharge and has a reasonable reason to go home. And she went home, and she actually managed to stay home for about 8 months, which I think is longer than anyone expected. So as an aside on this case, some of these cases cause a lot of team distress. And I think just making a plug for acknowledging that and making time for teams to sit together and talk about how hard things are. So here at the VA, a couple of years ago, we started this new program. Well, we didn't start it, but we adopted it. It's called the Unit-Based Ethics Conversations Program. And we had people come and do a 2-day training for us on how to facilitate these team discussions with staff. It's not a session to fix any of the problems, but to make space to talk about the distress and to identify some of the ethical principles that are relevant and to name those. And so far we found that it can be helpful to people when they've had one of these hard cases that's really caused a lot of distress. So the take-home points with this case, patients with decision-making capacity can make decisions their healthcare teams consider either bad or unsafe, right? Anybody out there ever made a decision someone else thought was bad or unsafe? I know I have. I'm not going to share, though. teams may want to consider ordering visiting nurses or getting a life alert, getting Meals on Wheels, etc., finding ways to sort of cobble together the safest plan if she really insists on going home. And then the team may consider calling Adult Protective Services when she leaves, but there is the risk that she's not going to let them in when they show up at the door. So I think, yeah, that gives us time for questions. I'm going to stop there and see if you guys have any questions or comments or anything you want to add.
I don't have questions yet, but I just sent the query out. So hopefully we'll get some in a moment.
Okie dokie.
Thanks so much for such a great presentation and tolerating all of our technological issues.
I've decided that's the new source of burnout, is like learning all these new technologies in like
Yes.
not very much time. That's tomorrow's talk, is burnout during a pandemic. Whew.
Well, we got a comment that said the presentation has been phenomenal. So that's good.
Oh, well, thanks, person out there. Appreciate it. I'm just going to drink my tea and try to stay awake here.
I'm wondering from the audience if folks have had issues come up, ethical dilemmas related to the COVID pandemic at the moment, but related to older adults who are experiencing cognitive impairment. So someone has asked, what are other cases where hospitals would get into liability legal issues other than forcing an individual to get into a nursing home?
Ooh, there are all kinds of legal issues. I mean, I'm not a lawyer, so I may be not the best person to talk about this, but you know, there are cases about who is, you know, legally authorized to make decisions for somebody, or sometimes we've run into the person actually was designated, so they are the durable power of attorney for healthcare, which is usually way at the top of the list, and yet then we find out that there is an Adult Protective Services case open against financial exploitation by this same person. And so that's maybe an example of sort of a legal issue. And I'm sure there are a bazillion other ones too.
Would they get into trouble if they decide not to give certain medications or treatments due to a patient's decision?
We've actually, it could be, sometimes I'm just remembering a case, this was not an older person with cognitive impairment, this was a younger person with very serious mental health issues, and that person's caregiver was lying to him and sneaking his medications into food. So that's potentially problematic, but that's not really the hospital doing that.
Yeah.
And that's not quite what you were asking either, but so it came to mind.
So here's a question, whether people in Montana can participate in the virtual support groups and chats you mentioned for caregivers or persons with dementia?
I think so. They just have to go in and register, because if you register, then you get an email that has the link to access that session. Does that make sense?
Mm-hmm. So in the hierarchy, could those higher in the lists override decisions made by entities lower in the list?
Right, so the way to find who the legal decision maker is you start at the top of the list, and then you start going down until there is one or more people in that category, and then they're it. So the people below them actually don't have legal authority to make decisions. Does that, I don't know if, did that answer the question? So example here, I'm going to pull up my slides. Should I go back? Oh, let's find one here. Okay, so if I'm here at the VA and somebody completed a durable power of attorney for healthcare, that person would be their legal decision maker when they lose decisional capacity. If I still sort of have my wits about me, somebody else can't come in and make decisions for me, right? If they didn't complete that paperwork, the next person would be the court-appointed guardian, but most people don't have that. The next, it goes down to spouse. So do they have a spouse? If so, that person steps into the decision-making role. And that, if you have a spouse, this happened to us a couple years ago, if you have a spouse who you haven't really lived with for the last 20-some years, but you never got divorced, that person is still your legal decision maker. If you're widowed and don't have a spouse, it then goes down to your adult children. And it's not the oldest or loudest or richest kid who automatically gets to be the decision maker. It's all the kids together.
So
hopefully that answers the question.
Oh, okay. Do you have suggestions about explaining facility quarantine simply to those with significant cognitive impairment? Maybe a simple explanation.
Oh, I don't have any good words. Maybe people out there have things they could share.
I'll keep monitoring the chat for that.
Yeah, I suspect, you know, and it's really devastating for people.
Mary Pat O'Leary says we're hearing about older adults, those with disabilities, and the use of masks that cover the face of the healthcare provider, and the disability community is concerned that the person who is hard of hearing can't lip read.
Mm-hmm. Yep.
Makes for difficult discussions, that's for sure.
Yeah, I mean, if one has access to a pocket talker, that can be really helpful. But yeah, do you take off the mask and risk sharing something with this person? You know, maybe you could have another person in the room who could repeat what you'd said, and they could read that person's lips. It's tricky. It's really tricky. Especially we have in our nursing home unit, we have one person with fairly advanced dementia who likes being out of his room, but he does not like wearing his mask at all.
So Lorraine mentions that she was happy you mentioned that people fall in nursing homes as well as at home. It's a hard concept for families to understand, she said.
Mm-hmm. Yeah. Yeah, and it's funny, our medical trainees always think that's true too. And yeah, we're not going to make falls go away.
Michael Chapman says, regarding driving and cognitive impairment, who's authorized to make decisions about a person's ability to continue to drive safely? Does a formal driving evaluation cover someone legally to drive safely, and who does this? The DMV, some vocational or occupational health programs?
I think it's DMV is ultimately the ones that decide. And different states have different rules about like whether we're mandatory reporters or not. The American Geriatric Society actually came out with a really good document about driving. I can't remember what it's called, but you can, it's available online. Hopefully somebody can find it. If you do like American Geriatrics, if you Google American Geriatric Society and then driving, I think you'll get to it. They have all kinds of, it's like 80 pages. It answers every question.
Okay.
I think.
Related to COVID, Paula said they're concerned about families who have the ability to change an advance directive to full code, full care at the last hour when resources may be scarce. That's a dilemma.
Yeah, and that's why I think having committees that are making these decisions and algorithms, because just as an example, at our VA or at VAs nationally, we cannot write DNR orders against a patient and family, which is a source of moral distress for clinicians. But as I said before, the VA autonomy is like higher than anything else. And that is one of the implications of that. However, if we get, with this pandemic, things get so bad that we move to these crisis standards of care where we don't have enough ventilators, then according to our algorithm, somebody with fairly severe cognitive impairment probably wouldn't get a ventilator, regardless of what the family wants.
So
the
Russell,
family, if we're not at that standard yet, the family can change their mind. That happens a lot.
Okay, Russell says he's curious if you have any thoughts on a patient that lives in independent living but clearly needs more help. The patient wants to go home to the independent living. What would you advise for discharge?
Well, if that person has decisional capacity to make the decision to go home, they've got their wits about them, but they're making what we think is a poor decision, maybe there are ways to get more resources into the home. So where was that? All of this kind of stuff.
Mm.
You know, it may not be quite as safe as being in a facility, but if the person's not going, what can we do to make things as safe as possible?
So Mary says that is wondering if the Seattle VA has clergy on the ethics team. She said that was one of the primary people on the team in Albany.
Mm-hmm. Yeah, I'm very proud of our ethics committee because we've got a chaplain, we've got social work, we've got psychology, we've got nursing, we've got doctors. So I think when it comes to ethics, having lots of different disciplines with different perspectives who are comfortable sharing their perspectives is really helpful for everyone to get the full story. And yes, we do have a chaplain. She's awesome.
Also, does the VA ethics system incorporate cultural decisions in values and our cultural differences, sorry, in values and ethics into its model?
Mm-hmm. Yeah, so when we look at the patient preferences section, when we're assembling our information, or we're looking at other perspectives, sometimes either the patient's perspective fits with some kind of cultural, religious values, or because that patient comes from a certain group, right? So maybe this patient comes from the Christian Science Church. So at that point, we would want to hear from our chaplain what that means. What are some of the tenets that go with that church that might be influencing what this person is asking for?
Can you recommend a decision tree or algorithm related to COVID care decisions that an ethics team might use?
Yeah, so the VA nationally, every VA in the whole country is going to use the same one. So, hold on, I got to look at all the piles on my desk here to find the name of it. Okay, so in 2010, the VA National Ethics Group came up with this, it's this big 80-page document that you can, again, Google. We're Googling everything today, aren't we? It's called Meeting the Challenge of Pandemic Influenza. So it's pandemic flu, but they have run this by the VA's national ethics people and the VA's lawyers, and this is what we're using. And it sort of outlines algorithms. It sort of recommends having these different teams and the roles of the different teams and who should be on the different teams. It's really good. I mean, I'm a little biased because I'm here, but yeah. And there are other different states are coming out with different, slightly different algorithms as well. I know Washington State has a group that has come out with some stuff, and there's a good one from Minnesota I've heard, and I'm sure there are other good ones too.
I think this person is responding to the question about a simple way to describe the distancing and masks for people with dementia. She said they've just used, "I don't feel well, I have a cough," with a lot of visual cues to convey that information.
Thank you.
Or maybe there's a bad bug going on out there, words they may be able to understand.
Mm-hmm.
And then how many times does Adult Protective Services need to be called before something is actually done? What can APS really do with the individual?
That's a good question. I don't know. I don't know the answer. And I think it depends again on the state. Some states, APS groups may have more funding than others, although maybe that's something that's being cut everywhere.
It looks like I don't have any other questions, so I think we'll just thank you for an outstanding presentation. This was really helpful and actually quite timely. There's another note here that just says the Geriatric Regional Assessment Team is under development within Sound Generations, and stay tuned.
Oh, yay, you're back.
Yeah.
Excellent. That
All
would
right,
be awesome.
thank you so much, Dr. Vig. We'll see everyone next week.
Okie dokie. Thanks, everyone. Stay safe out there. Be well.